Interesting about the virus is that it can transmit this virus, but it doesn't transmit chronicity. In other words, you can get infected by E antigen negative hepatitis, but you do not develop chronic liver disease from it. The difficult part of this virus is that, as I told you before, in the quiescent phase and the active phase and the inactive phase and in the quiescent liver and the E antigen negative hepatitis phase, it can be difficult to differentiate between the two because both are E antigen negative, both can have normal blood tests, liver function tests, and both can have low DNAs at one time or another. That's why, by definition, in the second slide I showed you, a definition of inactive carrier is quite strict. So anything above that, you must suspect that there's a possibility of a mutant virus, E antigen negative hepatitis. And in the last phase, the so-called occult phase, we know that hepatitis B tends to spontaneously clear in all carriers about 0.5 to 2% a year. They lose the hepatitis surface antigen, but they remain core positive and anti-HBs positive, some of them. The histology in these patients is usually mild and the liver is usually very good, and you consider most patients to have been cured of the virus. But in older patients, there is a small subset of patients who tend to have be cirrhotic. Now, there's recently a lot of talk about this occult hepatitis B because if you look at the liver, you find persistent hepatitis B DNA in the hepatocytes. And if you do some special blood tests on PCR, you can actually find a low level of DNA levels in the blood. Now, the problem with these patients is that there is a slightly high incidence of hepatoma in patients, especially if they clear after the age of 50, because the fibrosis is significant. And the other thing to note is that these patients tend to reactivate with chemotherapy. In other words, these patients under severe chemotherapy immune suppression tend to reactivate, become active. So it's something which so when we get patients who have got hepatitis B before, or for screening for chemotherapy, most doctors will do the surface antigen plus the anti-HB core. Now, so to summarize, the thing we are worried about in natural history is the occurrence of cirrhosis, because something you want to avoid. And so the things to look out for in the immune clearance phase is repeated attempts with no seroconversion, high ALT levels which are persistently high or repeatedly high. Okay, in the persistent E antigen positive patient at a late age, look out for in the reactivation phase, a seroreversion from E to NTE, from NTE to E or E antigen hepatitis, and most important is in all these patients always look out for persistent high ALT level and DNA levels. Again, we monitor cirrhosis patients because the E antigen positive patients tend to progress with cirrhosis 2 to 5%, and E antigen negative hepatitis 8 to 10%. Now, just a touch on prognosis of cirrhosis. Cirrhosis prognosis is generally good if it's compensated cirrhosis. It's generally bad if it's decompensated cirrhosis. So we like to see a patient with cirrhosis who is compensated if he's got cirrhosis. And now with treatment, we tend to hope that these patients actually do well. But generally, you got cirrhosis which is decompensated, then the prognosis is generally very poor. The last part is the incidence of carcinoma with hepatitis B. We have to go back to early people like Beasley. The overall incidence of hepatoma in hepatitis B patients is about 100 times normal. It's always worse if the patient is cirrhotic because the cirrhotic patients have got incidence of hepatoma 20 to 22 times that of a non-cirrhotic patient. Okay? And hepatoma is something which occurs about 30% in patients who have no cirrhosis. So hepatitis B is a condition which can give us a hepatoma with or without cirrhosis. Hence, it's always important to monitor your patients carefully. And the incidence of hepatocellular carcinoma goes up with age. And in cirrhotic patients, it works out to 2.5% a year. So it's a very high incidence. And we monitor hepatoma patients very carefully because the incidence of cirrhosis is real. So to summarize, in natural history, we always look for the age of the patient, the sex of the patient. How old the patient is very important because the older, the more prone to problems. Ask for family history of liver cirrhosis or liver cancer. Look whether the liver function, E antigen, E antibody, the DNA levels fit the natural history as you described. And always look for that any abnormal ultrasound or imaging. Because if the ultrasound or imaging shows liver cirrhosis, then this patient should be treated. So ask the patient, ask yourself whether the patient has got cirrhosis or significant fibrosis, and is he at risk of cirrhosis or disease progression. Any more time? Enough. No more time. Okay. We won't discuss the cases. I think I will just touch on the genotypes because one thing is important to tell the latest things. There are many genotypes available, been found recently in the world, of which genotype B and C are commonly seen in this region. Now, if you have hepatitis B, it's better to have hepatitis B genotype because it's an easier condition to treat and it's got less problems. The genotype B has got less progression of cirrhosis, low incidence of hepatoma, and earlier seroconversion. So by and large, you find that those patients who are bad, with a bad family history, probably may not be the family history hepatoma, may just be a bad virus. And genotype C is a lousy genotype to have. It's got late antigen seroconverter, and it's the most common cause of peritoneal infection because if you're a mother and you're 30, say you're above 30 and you deliver, if you've got genotype B, chances are you have a low viral load. But if you've got genotype C, chances are you have a high viral load. And we know high viral load tends to transmit easily to the baby. So unfortunately, I suppose the bad virus transmits to the baby, and most of us end up with a bad virus. And genotype C again is more common in ear hepatitis, although genotype B is responsible for early adult cirrhosis and cancer. And we know that genotype B is better with treatment with interferon and other drugs because it converts better with the drug. So we find that as time goes by, a lot of us will start doing genotypes to help predict the patient and sort of give us a guide as how we can treat the patient. Thank you very much.
Thanks, Roland, for the very interesting and insightful lecture. Next, I would like to introduce to you our chairperson that put together this book, Professor Roland Chong. She's a senior consultant from the Department of Gastroenterology and Pathology Department in Singapore General Hospital. She will give us an update on recognizing chronic hepatitis B virus infections, clinical manifestations, and gastrologic diagnosis.
Just give me a minute just to load the slide. Maybe while waiting for the slide to be loaded, I guess just want to say the reason why I, other than the usual natural history, then go on to how to manage and treat, why I added the element of serology and to give a preamble to Richard's talk on vaccination is after our CPG guideline is out, there was some query about why anti-HBC total was is included as part of the screening for pre-vaccination. And actually, we do take everybody's feedback seriously, and we have re-looked at it. Not that it is not required, but we understand from a primary healthcare setting, maybe you may not want to do it up front, but nonetheless, so we have actually modified it a little bit, just so that it's still loading. Something is wrong, I think. Double click? No. Okay, but so as I was saying, so what happened is as a result of which we thought we have actually revised it a little bit just to give everybody the flexibility. But nonetheless, I thought it's good to just to explain the rationale, and Roland has already mentioned in passing about occult hepatitis B and all the issues. Part of the reason we do the revision is also based on our clinical experience in the recent year. Thanks, in a way, to all the new immunosuppressive agents for chemotherapy, which make a lot of our cancer curable, but they are also so fierce and so immunosuppressed, and exert such strong immunosuppression that it can give rise to problem. So hence, now we are, just like Roland said, on one hand, we're giving more emphasis on looking at HBV DNA. People are also giving more emphasis looking at anti-HB core, and I shall explain that. Okay.